This year at ASH, again, lots of immunotherapeutic strategies were evaluated in multiple myeloma. One of the most promising is Daratumumab, and there were two interesting updates, one on the POLLUX study and one on the CASTOR study. And with prolonged follow-up, we still see the enormous advantage of adding Daratumumab to Lenalidomide Dexamethasone or Bortezomib Dexamethasone. And what we also see with prolonged follow-up is that the responses are still increasing to get deeper. So that's very important because deeper responses are associated with a longer survival. And we also see now a quite high percentage, an unprecedented high percentage of MRD negative disease in myeloma patients treated in the POLLUX study, in the Dara-Lendex combination and the Dara-Bortezomib combination. And these patients that achieve MRD negativity really have a very good progression-free survival, and hopefully this will also translate to a very good overall survival. In this ASH meeting, also the data on high-risk cytogenetics was shown in the POLLUX and in the CASTOR study, and high risk was defined as deletion 17p, 414 translocation and 1416 translocation. And in both studies, the triplet combination was able to partially overcome the poor risk conferred by these high-risk cytogenetic abnormalities. However, it was not fully abrogated. But as compared to the doublet, the triplet with Dara was really able to shift the curves of the progression-free survival upwards. When you look at the toxicity profile in both studies, then you can conclude that Daratumumab is well tolerated. The only thing that is important is the occurrence of infusion-related reactions, which occur in approximately 50% of the patients. And also the first infusion takes approximately 6 to 7 or 8 hours, which may be inconvenient for the patients and for the doctors because you have to plan enough time for the whole infusion. So one very interesting development is that there is now also a subcutaneous formulation of Daratumumab, which can be given in 20 to approximately 30 minutes. And it's a volume of 60 to 70 ml. And this can be given subcutaneously because there is also an enzyme in this formulation, hyaluronidase. And this enzyme creates space by degrading hyaluronic acid proteins in the subcutaneous tissue. And what is interesting is that the infusion time, as I mentioned, is going down from 8 hours, the first infusion, to only 60 minutes, 40, 60 minutes, which is very convenient for the patients. And what is also important is that the infusion reaction rate is going down from 50% to 24%. So also that, the side effect profile seems to be even better than the intravenous formulation. So I think this is also a very important step forward. Other antibodies that are being presented at this ASH were Pembrolizumab, an anti-PD-1 inhibitor, and this antibody was combined with Pomalidomide Dexamethasone in extensively pretreated patients. And also data from this triplet combination were very promising, with high responses, and the combination was pretty well tolerated, although you have to be aware of autoimmune phenomena that can occur with, when you combine an IMiD with a checkpoint inhibitor. And then finally, before I conclude my presentation, there were also several presentations of CAR T cells in myeloma, BCMA-CARs, CD19-CARs, and upcoming APRO-CARs. And I think we will hear much more about these CAR T cells in the next ASH meetings. So I think multiple interesting immunotherapeutic developments in multiple myeloma, which will really improve patient care and patient survival.